You are listening to Personalization Outbreak, a podcast about the collapse of traditional corporate standards in today's more personalized world. I'm Llopis. I'm a leadership strategist, author, contributor to Forbes, and founder of the Leadership in the Age of Personalization movement. On this show, I'm interviewing executives across multiple sectors to find out how the balance between standardization and personalization can exist. Hello, everyone. Welcome to Personalization Outbreak Podcast. A massive nursing shortage is threatening to disrupt the U.S. healthcare system. But here's the catch. It actually isn't about not having enough nurses. What's the real issue? A shortage of jobs that nurses are willing to take. See, this isn't something that we can simply fix by hiring more nurses. True change calls for systemic improvements in workplace culture and leadership to attract and retain nursing talent. Now, to help us better understand and address tangible solutions to this nursing crisis is our guest and my new dear friend, Dr. Olga Yakusheva, who brings a unique and invaluable perspective to the intersection of economics and healthcare. As both an economist and a professor of nursing at Johns Hopkins School of Nursing, she's at the forefront of redefining how we understand and measure the value of nursing within healthcare systems. In the International Journal of Nursing Studies, Olga and her co-authors, Catherine Lee and Marianne Weiss, wrote a highly compelling study that's titled The Nursing Human Capital Value Model. It challenges the outcomes over cost approach to nursing economic value, which often results in what? Underfunding and staffing issues that harm both patient care and organizational performance. It redefines nursing's value as the return on investment in nursing human capital. I highly recommend that you read this study. You know, this is one of those studies that kind of crosses your desk and you say, well, is this just something that I've heard before? And the answer is no. Just wait till you experience Olga. She's not only bright, but she's charming. And she has this charismatic way about her that'll make you feel accountable, but also make you feel like you need to take action. Because see, the nursing human capital value model, it presents a cycle where investments in nursing actually lead to improved outcomes, increased revenues, and further reinvestment in nursing. Now, this model advocates treating nurses as value-enhancing contributors, essential for sustainable, high-quality, and equitable healthcare systems. Olga, thanks for letting me have you on the show. I'm so grateful that you're here, that you've taken the time. You know how I feel about you. Thanks again.
Thanks, Glenn. It's great to be here. And it's amazing that you call me a friend and you call me a friend and a charming person. That is wonderful. Thank you. That is the warmest introduction I've ever had anywhere.
Well, see, this goes back to personalization, right? When you see and know someone as an individual, you actually have the permission to say those things, and you've actually given that to me. So I actually thank you because that's what this is all about in the end. And if we can't see that same value in nursing for what they mean to healthcare systems, then we got this all wrong. So this takes me back to like, why are you so passionate about this, Olga? And what really led you to pursue a career as a healthcare economist? Like, I mean, people ask me all the time, how'd you become an author? These are things that are not on the career center board when you're in college. How'd you get to where you're at today?
So it's really interesting because so many people ask me, especially in economics, why are you studying nursing? Right? Nurses are they're just there, right? The majority of my colleagues, they study physicians, pharmacists. They look at how organizations work. They look at policy assessments and all of this. Why do you study nursing, right? And if you think about it, just imagine if you were landing on an alien planet, right? You are human on an alien planet. You look at the planet, and there's all of those creatures running around, right? And you cannot tell one creature from the others, but you see that one type of creature is the most populous. There's the most of them on this planet, and it also seems that every other creature on that planet comes to this one or two or three times a year. to do something. You don't understand what they're doing, but you see that everybody needs this one creature. This one creature runs around. That's the most of them. You would think these creatures are the kings, the most high society, the most level, the most high society on this planet, right? And that's the one you would start by studying, right? You'd be like, I'm gonna do these ones first, and then I'll do everything else next, right? So that's how I kind of feel about nursing, right? Nurses are the most populous healthcare workforce. They're the most populous workforce to begin with. There are over 5 million nurses out there. There are more nurses than the retail salespersons. There are almost, what is it? Several times more nurses than physicians. I'm forgetting the number now. We can record this later, but nurses are the most populous profession out there. They provide the majority of care, and I am terrible at this. And I don't know how. Like when the camera is on, I can't talk.
You're doing great, but let's go back. Why nurses? Like, when did you know that that group on that alien planet mattered a lot to you? Were you there to advocate for people that didn't understand their real value? Like, what was it? What triggered it?
So I had a personal experience. I might have shared it with you earlier, where a nurse was really important to my family. Well, actually, a group of nurses. When my mother was really sick and dying back in Kazakhstan. I am from Kazakhstan. I went there and I took care of her for the last several months, 3 months of her life. And it was a very, very difficult experience. And I stayed in a hospital room with her in Kazakhstan and was allowed to have a family caregiver to be present in the hospital with a very sick patient. So, and I observed the care that my mom was receiving. And the majority of it was given by nurses. And that was the care that was important to my mom and to me, because there was nothing that could be done for her medically anymore. It was just sort of ushering our family towards a dignified exit entry into the next world. And we all knew that's what was happening. And yet the physicians would come into the room and they would almost kind of like not look my mom in the eye, and they would be, oh, you're doing so great today, Nadezhda, and your test results are really good, or your blood is amazing, or your lungs are working really well, right? And it would almost feel like a disconnect between what was happening and what the physicians were saying. And I would always encourage my mom, right? They would always tell her that she was doing good, which at some point in time, you understand that encouragement starts falling flat when you know that things are not good and they're not getting better. And the nurses were the ones who held their hand through all of this, right? It was I had an amazing connection with this wonderful women. They were there when I was there. They were there when I was not there. They would give me updates on my mom. They would encourage her, but in the ways that were not they were honest. And that was very, very important. And I also noticed that as important as nurses were to me as the patient, to my mother as the patient, and to me as a caregiver, and to our family, they didn't seem to be valued by the healthcare organizations, by the hospital we were in. When the physician would walk into the room, the nurses would just kind of blend into the background. When physical therapists would walk into the room, they would blend into the background. When the janitor would walk into the room, they would sort of try to stay out of the way of the janitor. And it seemed like every other individual coming into the room was more important than the nurses are. But from my perspective, nurses were the most important. So all of those interruptions, they were difficult. They were difficult. They were painful in the process of sending my mom off to I'd like to believe the next life in a dignified way. So nursing, that's where the first time I realized how important nurses are to patients and how important they're to families. And also being an economist, I was looking at sort of the signs that nurses were not treated well and not valued sufficiently by the organization, right? They didn't seem like they had the best clothing. They didn't seem like they had the best cars. They didn't seem like they were treated equal to others. And at that point in time, I thought, I wonder that sense of being born and raised in a communist, socialistic society, or whatever you want to call it. I am very sensitive to injustices that are persistent in hierarchical structures. So I'll put it this way, right? Because those injustices, they're being perpetuated by the system, and that system sort of, it thrives and rides on the back of the people whom it exploits, right? So that's how our communist system was. That's how our socialist system was. And when I was looking at nurses, it sort of aligned in the same triangle to me, that they are the backbone, the true foundation of the healthcare system, but they were not treated like they were. They were in some ways undervalued, underestimated, under-resourced, financially under-resourced, right? They did not have the same quality of life and the same financial security as other people within the healthcare system did. So that deep sense of injustice is what truly drives me to try to advocate for nursing, to try to apply the economic lens and demonstrate the importance of nursing, right? It's the disconnect between how important nurses are to the healthcare system, to patients, to families, to the society, to the outcomes, health outcomes that our healthcare system is able to produce, and how unimportant this seems to be when it comes to decision making, when it comes to resource allocation, when it comes to policy making, when it comes to being able to have a fair share of the resources that are out there, and asking, demanding, and making those decisions. So that's why I'm doing this.
Wow, Olga. First of all, thank you for sharing something so personal. I felt it in your voice. But what I also felt was that you're in this for the right reasons. And oftentimes I see people in high roles or powerful, influential roles that we think they're in it for the right reasons. And then we realize that their noble intents swayed into other directions. And so for you to be personally connected, just as you are professionally connected to what you do, is powerful. And I appreciate that. And, um, as I was listening to you, uh, you reminded me of how when you kept saying blending into the background, this is a product of standardization. When you think that you're not worthy enough and less than just because your title or whatever you've been deemed in whatever box or label makes you feel as if you have to pause and give others with perceived more influential titles um, the power or the ability to stand out in front. And what you're basically saying is that no, these systems are now changing now, and it's not about titles or boxes anymore. It's really about the influence that certain groups of people or individuals have that actually carry more weight at a different time in the world, where actually they're needed more than those that we have historically perceived to be the most prepared for times of volatility right now. And so I share this because this is a perfect example of how the way society values certain people or types of people um, overshadows those that never had an opportunity to show that they were actually just as worthy. How did I do there?
Well, I think what you're saying is the way we value people in terms of sort of the personal and emotional value we place, and the way that the people are valued by the system in terms of being able to feel good and valued in your workplace, and being able to bring home, and I will say bring home an income that allows for the quality of life that makes you feel valued, and your children and whatever, your pets, whatever your family, it can allow you to have enough value to give value to them too, right? Those are the two things that are misaligned, right? And I think that's what you're saying. Nurses are valued, right? Nursing is the most trusted healthcare profession for forever, I think, since Gallup started the list of most trusted profession, with with the exception of 2001, when firefighters were the most trusted profession.
Mm.
Remember when the Twin Towers
Yeah.
collapsed? That was the one year
Yeah.
when firefighters beat nurses in that ranking. All of the other years, all throughout history, nurses are the most trusted profession. So we do value nurses. It's just that that value does not translate into the economic value, right, within the healthcare system. And it does not translate to nurses feeling valued, right? Because no matter how you look at it, our healthcare system is a market-driven healthcare system. As much as the government is intervening and trying to regulate the markets to try to make it more fair, more equitable, higher quality, right? The fundamental underpinning, the economic underpinning of the healthcare system is still very much based on treating illness, right? Taking care of things after the fact. When somebody is already feeling unwell, they go to the doctor, then they go see the doctor, they go to the hospital, right? And each time they go to the hospital, they feed the healthcare system, they feed the monster, right? And this monster really likes money, it really likes to eat, right? And because the monster likes to eat, our healthcare system is not what you would call a healthcare system. We have a sick care system, right? The way that it's set up monetarily, it's not, the economic driver there is not to cure people and keep people healthy and well. The economic driver is to keep people as sick as possible for as long as possible, so they keep coming back, right? We don't want a patient cured, because then they never come back and they do not feed the monster. We want the patient ill, just not dead. And that's sort of, it's terrible to say. When I say this to people, they feel like I'm a pessimist, or I have a very bad view of the healthcare system, but that's just financially how it is set up. It's it's 90% volume based. Its quality has a very little aspect in it. And when you have when you have society that wants quality of care, right, to which nurses are completely pivotal, and we all know this. And we have a healthcare system where the financial gears turn in a way where the quality to society does not translate into financial resources and money to the organization. It doesn't feed the monster, right? You have this misalignment where the most valuable, trusted, amazing profession in of all of the entire labor market is not it does not feel valued in the workplace.
So on that note, I didn't expect to ask this question, but now that you bring this up, on a percentage basis, physicians and nurses, which one of those groups contributes most to patient care and quality?
Well, I think it depends on the setting, right? If you go to primary care, right, the majority of primary care is delivered at this point in time by physicians, right? You go to specialty care for diagnosis, the majority of care in those settings is delivered by physicians. You will see the nurse who will come in and take your vitals, right? But the majority of the main reason why you're seeing somebody outside of the hospital is for a physician. And I will say that there are nurse practitioners now, right? They have in many states the same scope of practice as physicians. And those nurse practitioners could, every once in a while, you will go to a health clinic, you would go to a primary care doctor, and you're seeing what I call a doctor nurse, right? It would be a nurse with a doctoral degree in nursing practice, and he or she will see you, and you will actually not be able to take the difference, to tell the difference between the quality of care you're receiving. At least me as a patient, I can't tell the difference. So that's
let's go ahead. Olga.
Oh, but I was gonna say, excuse me, that's in ambulatory care. Now, when you move on to hospital care, you actually go to the hospital for nursing care, right? Because if it's not for nurse, if you did not require specialized nursing care in the hospital, then you could have been at home, right? The physician could have come, like think about the old family doctor model. The doctor comes to you at home and they tell you what to do, and your mother or sister or whatever help you with your personal care needs. Now that model died, and we opened hospitals because hospitals were the place where people could go and receive nursing care, right? Where nurses would follow the directions and instructions of the physicians, right? To provide care, that you would need in terms of your recovery or getting better with the illness that you have. So hospitals, the majority of care has been estimated at 80% of hands-on patient care in hospitals and acute care settings is delivered by nurses. Nursing homes, even more than that, right? Nursing home, it's the majority of it is nursing care. So depending on where you go, but overall, nurses are the most populous, largest healthcare workforce, and they are across care settings. Now, if you look at community, right, schools, other types of community institutions, it's usually nurses, hardly ever physicians, right? So yeah, nurses are absolutely pivotal to our healthcare system, particularly in hospital settings and nursing home settings where the care tends to become the most intense and the most costly.
So this takes us to the nursing human capital value model. Now, your model, Olga, emphasizes the ROI of nursing human capital. How can organizations effectively measure this ROI in both qualitative and quantitative terms?
So what I mean when I say the ROI in nursing, it starts with the concept of, so ROI, return on investment, right? It starts with the concept that you have to invest, right? You have to invest for you to be able to earn the ROI. And that's very different from the general approach that I see in health services research and actually in healthcare out there that looks at nurses as overhead, right? Nurses are a budget item that if we want, that's the thing, this is the thinking, right? If we want to deliver affordable care, right? And we want to increase access to patient care, we have to reduce all of the costs, and nursing being one of the largest single cost items on the healthcare. If you imagine the healthcare balance sheet, right, for the entire healthcare system, nurses are the costliest, one single costliest item there, right? So that seems to be like an easy thing to address in terms of cost reduction. What we're not thinking about when we apply cost reduction towards nursing is that connection between nursing and quality, right? And nursing and outcomes, forget quality for a second, but nursing and outcomes, right? For a hospital or a nursing home to be able to have the bed open, hospital has to be staffed. The nursing home has to be staffed by nurses. And I like to do this thought experiment where I imagine a healthcare system, right? And who do you have in healthcare system? You have various types of people working there. But let's take three largest ones, right? Let's take administrators, physicians, and nurses. And imagine the fairy comes and just a thought experiment, right? And the fairy goes like this with her wand, and all of the administrators disappear. You would probably not even notice for a little bit, like a couple of hours, you won't notice anything, right? And then you're like, well, where did they all go? And then you figure it out. The patient care continues, right? Patients are being seen, patients are being cared for, everything is going well in that regard. Now, another thought experiment, imagine the same fairy comes and she goes poof, and all of the physicians disappear. That will be noticed immediately, right? Noticed, missed, but the healthcare system will continue to work, right? Because nurses can't keep it up. They can't hold down the fort for a while, right? There are nurse practitioners now that can replace physicians in some of the main major functions. There are nurses who are highly experienced who will just be able to hold down the fort for. When I ask nurses, they say maybe a week or two. Of course, surgeries is a special case, right? Surgeries would need to be postponed. But again, nothing will come to a crashing halt if physicians disappear immediately. Now imagine if poof and all of the nurses are gone. You will immediately notice, right? Because all of the nurses that are doing IVs, holding the patient's hand, taking information, they're not there anymore, right? And the healthcare system cannot literally immediately comes to a screeching halt. So when you look at our healthcare system, it's literally nursing is the core function to it, especially in acute care and long-term care. Nursing is the core function. So yes, when we think about this core function as overhead, and we try to reduce cost of it, we're forgetting about the fact that this workforce and the well-resourced nursing workforce is absolutely pivotal to the production of outcomes. And that is also the thinking that's sort of perpetrated by the current view of the value of a healthcare value, right? It's outcomes divided by costs. There is no link between healthcare outcomes and costs in that equation. It's just a ratio. It makes you think that to provide high value care to your patients, if you're a perfectly well-meaning, benevolent, kind person, and you run a hospital and you want to provide the best value for your patients, you want to, at the same time, improve the outcomes and reduce the cost. And without understanding how important nurses are to the outcomes, you think it might be possible, right? So when we end up in a healthcare system that consistently over time reduces cost and reduces resource availability for nurses, while also trying to improve outcomes. And there's only so long that you can do that. At some point in time, all of the slack in nursing is gone, right? You are running on bare fumes. Nurses are running on bare fumes right now. So it's no longer possible to reduce the cost of nursing while holding the quality or improving the quality. And that's where... What's that?
Go ahead. I'm sorry. Go ahead. No, go ahead. I'm sorry.
No.
Go ahead.
And I was just saying that the idea of the return on investment, that the nurses is a capital. The idea there is that there is a strong connection between the nursing human capital, right, and that's the education, experience, expertise, the qualities, not just the quantity, but the qualities that nurses bring to the workplace. That is incredibly important to the production of healthcare, right? This is a key asset to the production of healthcare. So if you don't invest in nursing human capital, you're not going to get the improvement in outcomes. If you disinvest from nurses, you can get a short-term reduction in cost and maybe a short-term profit margin somewhere there. But long-term, it's going to come back and bite you, right? Because it's saving, what is the expression? Saving a penny to lose a buck?
Yeah, exactly.
Yeah. So that's the whole idea of thinking of nurses not as an expendable resource, not as overhead, but a human capital that is strengthened by the diversity of experience, education, personal characteristics that are embedded in each individual nurse. And only by amplifying and investing in that human capital is how organizations can survive and thrive economically in the long run.
Do you think that executives in healthcare see nurses as human capital as you've just defined it? Or do you just see it, do they think of it as just a cost center?
Well, I think, I don't think you can generalize to all of the executives out there, right? So first of all, there are organizations that are very cognizant of the importance of their nursing staff, right? And those are the organizations that there is some rankings of what organizations are best to work for, and nurses, so there are some organizations that really do invest in value of nurses. And I just don't want to name any names right now. You can look up at those you can look those ratings up. They're all up there. But I think in general, executives, it's not that they don't care about nurses. It's just that the financial model is such that they almost can't afford to really think about nurses as human capital, right? Because it's all based on their job, their role. Okay, so I'm going to say this. An organization only thrives when everybody has their role, they know their job, right? Ultimately, it's a team, right? It might not feel like a team at some point to key players or nurses. It might not feel like a team, but a well-functioning organization is a well-functioning team. And everybody has their role. And nurses, in some ways, they have the wonderful role, and their mission is to care for patients. And if I were to choose one of those jobs within the organization, I would choose that one too, because I'm a kind person and I want to be good ultimately. I would never be a CEO, right? Because a hospital CEO, their job is to make sure that the organization thrives financially, right? That it has more revenue coming in than there's a cost, than they have this profit margin, and that they invest that profit margin or invest their resources in the way that generates the highest return on investment, right? And the problem is right now that because our healthcare system does not value quality of care or nursing financially, nursing is hardly ever at the top of those high return on investment priorities on the organizational sort of priority list. So I think we know nurses are important. There is a lot of literature out there, a lot of studies out there that shows how important nurses are to patient outcomes, to organizational outcomes, to community outcomes. I think we all know that. I don't think anybody saying, oh, nurses don't matter. It's just that when the rubber hits the road and it goes to money, and money goes to where it needs to go, right? And that's the law of market economics. Money goes to where there is the highest return on investment. And that's sort of why the human capital value model that conceptualizes nursing value not as the outcomes over cost equation, but a return on investment is a pivotal change we need to put nursing on this return on investment map and quantify, understand, elevate, and disseminate the high return on investment opportunities within nursing. That's what we need, I believe.
Okay, so on that note, how do you suggest that healthcare organizations balance that short-term financial pressure with the long-term benefits of investing in nursing human capital?
So I think it's hard, right? I think it is a long-term investment. I think it takes a leader who is in it for the long haul, right? To understand that nurses are an important asset. What happens essentially is think about renting an apartment versus owning a house. Our healthcare system, our healthcare organizations are renting nurses instead of owning and putting their investment in the value of the nursing staff. That's why you're seeing high turnover. That's why you're seeing lack of resources or insufficient amount of resources that goes to nurse retention. That's why you're seeing young nurses leaving the profession within 2 to 3 years, right? Of just coming out of college, being fresh and bright-eyed and wanting to care for patients, coming into the workplace and not being able to stand what's happening, right? Our healthcare system is consistently renting nurses. And travel nursing that's growing in numbers right now, right, is part of it, is a symptom, right? It's not a cause, right? It's not that. I think a lot of times within nursing, there is this sort of almost like a professional dislike for travel among staff nurses who are attached to the hospital. There is a dislike of the travel nurses because they come in and they get a lot more money than staff nurses, and yet they're not attached to the organization and they don't know the patients and they don't know this. But it's not about travel nurses. Travel nurses are not the ones that are, or the institution of travel nurses is not the one, is not what's causing understaffing and lack of resources for staff nurses. It's the system, right? It's the system that makes it cheaper to rent nurses than to invest in nurses. Again, it's because right now our healthcare system is not focused on quality, or financially is not giving enough return on quality. And until it starts giving return on quality, it's hard for organizations to really put their money where me as the patient wants it to be.
So what's the risk profile here for patients? Something doesn't seem right. What's the risk in not viewing nurses as human capital and thinking so much about the short term that, we're not even thinking so much about quality. It's not part of the original model. So what's that risk here?
The risk is, I'm trying to find a term that does not exaggerate it. It's significant. right? And the risk comes from the fact that when your nurse is overworked, when she or he works several subsequent shifts, and they're taking care of you, they don't have enough internal resource to give to you, right? So that's where mistakes happen. That's where what we say, things are not done the right way, right? Administration of medications administered not in the right dose to the wrong patient. And it's not the nurse's fault, right? It's just we're all human. In 2020, the AOM, American Academy of Medicine, which is the name of it now, issued the report to Earth Human, right? So, and that report said, look, when mistakes happen in clinical practice, it's not the clinician's fault. It's the fault of the system, right? And we have to improve the system to try to prevent those mistakes. It's not about scapegoating the clinicians who are making the mistakes. It's a symptom of a larger problem, right? And here, what we have right now is nursing is under-resourced, understaffed, and patient care is not as good as it should be. There's a lot of studies that link nurse understaffing to increased mortality, to reduce failure, to increase failure to rescue, right? You're actually literally more likely to die when nurses are understaffed. Because when nobody goes to the hospital, it's not a spa, right? If they screw up your manicure, you're fine, right? If they screw up, I shouldn't say screw up. If your care is not delivered to the best standard, you die, right? So these are the risks. These are the odds we're playing with, and they're not very favorable to patients.
So what type of immediate actions be taken to begin implementing your model around the nursing human capital value model without straining existing resources?
Yeah, so the first immediate action is that nurses themselves must see themselves as a human capital and not costly overhead. There's a lot of guilt in the nursing profession about asking for more money or asking for salaries or asking for more resources, because the current narrative is that if nurses cost more money, it's going to cost more to patients. And nurses, their professional ethics does not allow them. And these are amazing people who really are driven by their value, right? There is a reason why they're the most trusted profession. They're not, it's an understatement to say they're uncomfortable to go for measures that will cost patients more money, right? It's against their moral sort of ethical norms, right? So, and the vision right now is if we invest any more, a dollar invested in nursing is going to cost somebody more money. And that vision needs to be eradicated within the nursing profession first, right? Nurses from the first time they step into a nursing school, they should be taught that you have value, you are value, right? You are not a cost to the organization. You are value to the consumer, you're value to the society. Every time you step into the hospital, you produce value. And it's okay that there's a cost associated with it, right? We all understand that if you want a really good apple, you have to pay more for it, right? But that's the price you pay for value, right? It's value that we want. It's okay that if we want a nicer car, we pay more for it. And a lot of people drive cars that are slightly more expensive than they would have otherwise, but the quality of it is good, right? It's more gas efficient. It's better for the planet. It gets them to the right place quicker. There are lots of things, right? So it's not always that you get value by spending less money. And that's what nurses must understand, that they are valuable and therefore they must be valued, right? It's not about just because you like your job does not mean that you can't be paid well for it too. Just because you love your job must love you back. And that's sort of like a fundamental shift that needs to happen within the nursing profession. Nurses at this point in time, and I will say, I have so much admiration. That's where my deep sense of injustice comes from. They view themselves as selfless, benevolent servants almost.
Wow.
Right? They go into the profession to serve their patients. And my cat.
It's okay.
They go into the profession to serve the patients and to put the patient's need above their own needs. I mean, think of any other profession where your needs are put above the needs of the person who is helping you, right? Who is there, who is working there. It's not like that anywhere. Maybe clergy.
So Olga, how do we get nurses to shift their mindset to value what makes them valuable? I mean, look, let me just give you an example. Having worked with several nursing leaders, it's clear in nurses, it's clear that they feel as if they have a certain place within the organization where they fit, and that's where they fit, and that's their home, and that's what they do. Um, but I've also seen that once they realize what their value is, um, then they start recognizing not just how suppressed they've made themselves feel, but that there's been missed opportunity, not necessarily for them, but for the patients and the actual organization that they work for to add more value to it rather than just fit in this particular box. But so I've seen firsthand what happens when they shift that mindset. But what do you think is holding them back to turning on that switch to say, I matter, I'm valued. Yeah, I love I love the profession, but this is not a job. This is what I'm doing is really helping influence the outcomes of why we even exist. How do we get them to see that?
Well, I mean, it starts with education, right? It starts with nursing education, right? It's I'm even afraid to say that, right? But when we think about the fundamental premise of nursing, and I've been in the School of Nursing for 10 years, right? So I know some things. I don't know all things. So if I'm wrong, please write to me and correct me, right? But my view of it is that nursing is based on the sort of benevolent servitude type principles that go back to Florence Nightingale, right? And Florence Nightingale was a rich woman. She was not where most nurses are right now, right? And for her, she was also an economist and a social reformist, right? So for Florence Nightingale, it made the way that she saw nursing was a vocation. It was a way to be good to the society. It was a way to improve life, to leave a legacy, to do something better, right? But she never relied on nursing as a way to feed her family,
Mm.
right? And that's where nowadays it's not like that anymore, right? Very few of us can afford to do something regardless of whether it pays or not. Very few of us can afford to be selfless and serve and not expect that you are supposed to be supported by and valued financially as well by the organization where you work, right? And that's where I feel like nursing attracts people who are already benevolent and kind and incredibly giving, right? And then through nursing education, they become, this is encouraged and they become even more so. And nobody ever tells them. And that I know for sure, that I know for a fact, that if you love your job, your job must love you back. You have to be able to say no, right? You are participating in the labor market, right? Patients are being billed for your care. That's the other thing. Nurses feel like if they're not getting paid a lot, or if they're not billing patients are not being charged for the care that they provide. They are, right? So it's not a matter of if I am humble and I serve my patients and I put my patient first, then somehow the cost of care is not there. And it's also not the fact, not true that if nurses ask for more, that gets billed directly to the patient. It doesn't. It's just about the reallocation of resources, of financial resources that are within the healthcare already. Nurses earn a lot of it, a large portion of the financial resource revenue that is earned and churns within our incredibly expensive healthcare system is earned by nurses. Nurses just don't have a direct line of sight of the revenue they're generating. And they're being made feel like they're the cost, where they actually are the ones who are generating this revenue. So it starts, you ask me, where does it start? So it starts with in nursing school, right? It has to be, I'm sorry. It has to be an understanding that you generate value, you're valuable, right? You have talents, and those talents are for the betterment of the patient, of patient care, right? And it's never not your place to say something, right? Because when you understand your own value, you will never be put into a box or a spot, right? Or stick to your spot, right? You when you know you're valuable, and when you're seeing that what you say or what you feel has direct and maybe not so direct, but has implications for patient care, right? You have to say something, right? And you have to feel like you can, and you have to feel like it matters. And that's what needs to be taught in nursing schools. In addition to that, nurses must be taught is a bad word, but nurses must be introduced to how our healthcare system runs, right? And how revenue is generated and where the money comes from, right? That's part of almost like home economics, right? That should be taught. And I don't want to give it a derogatory term, home economics, something for girls, right? Not at all, but that's sort of understanding of where the money comes from and where it goes, and how, what role I have in this is also very important for nurses. And I know there is some of it in leadership courses, and they're usually, part of the curriculum in, second, third year of baccalaureate degrees. I don't know how much of leadership education nurses get in, nurses with associate's degrees get, but that's fundamental. It's like being able to write a check. It should be part of a core fundamental year one course, an explanation, understanding of how the healthcare system works and where the money goes. And it's pivotal for nurses, because nurses are so pivotal to the healthcare system. They're everywhere. They must understand it.
Olga, look, I appreciate you taking on that question. Why? Because this is where your advocacy comes in, where you can take your economic side with your research side on your nursing human capital value model, and bring these two things together to help nurses realize that the only barriers that are being creating are the ones that are self-inflicted, when there's so much opportunity for them to give rise to the profession and its even more valuable role that it serves in today's healthcare marketplace, where there are new populations entering hospitals, where there's new disease states, where there's so many new challenges, that the value of nursing just continues to rise every single day. And in the end, this has a lot to do with reimbursements too.
Right?
So there's so many different angles here to where you're going, that it's enlightening me on giving rise to nursing. So thank you for taking on that question. I know it was sensitive, but I think the way you framed it is really good, because unless people understand how people make money and how their institutions make money, and they understand where they fit in that entire equation, can they start realizing, and by the way, not only the value that they're driving to the bottom line, but the intangible values of how they are influencers of the very communities that these hospitals are serving, who are trusting who? The nurses. So there's so many angles here. We're going to start wrapping this up, and thank you for staying on a little bit longer. You okay?
I'm okay. I will just say that I will take a slight objection to what you said. You said these
Go.
these are self-inflicted. They're not all entirely self-inflicted, right? There is a history of oppression of women. And nursing is predominantly a female profession. There's a history of oppression, or how do I want to say, resistance to nurse leadership within their healthcare system. There's a history of nurses being told this is your place and you stick there. There's a history of being undervalued, and that history has an impact, right? So some of the ones are self-inflicted, but a lot of it comes from just the way that traditionally nurses are being viewed within the healthcare system and treated within the healthcare system. And that needs to change. But I will agree with you when you say that nurses are the only ones who can fix it. Nobody will fix this for nurses. Nurses are the only ones who have to fix it. Nobody will take care of it for them.
Thank you for that, Olga. Thank you. Okay, so what are the implications of your model with respect to policymakers and healthcare payers in terms of incentivizing and funding investments in nursing human capital?
So there are two things. One thing is I will tell you a little bit about how the reimbursement system works, right? And very, very simply, the reimbursement that a hospital gets for patient care does not depend on the cost of nursing within that hospital, right? So it's set based on national benchmarks, right? And when you get the same $100 for patient care, regardless of whether or not you spend, $70 on nursing care or $50 on nursing care, you understand very quickly that the financial gears are turning against nursing, right? Because if I spend $50 on nursing and I get $100 back, then I save $50 and that goes to my profit margin, revenue margin, right? And that, in the best scenario, gets spent on investments in other facilities, buying out other facilities, investments in new medical equipment. Very rarely does it get spent on nursing, right? And that needs to end, right? So there has to be a direct connection between how much a hospital spends on nursing and how much reimbursement the hospital gets for patient care, because the majority of it is nursing, right? And I have a model out there that I propose that actually tethers the two, where a hospital reimbursement is based on the cost and quality of nursing care within that specific facility, not on national benchmarks. So that's part one.
So just really quick, so correct me if I'm wrong, but I heard you say in so many words, the way it's currently done, nursing is actually helping finance other parts of the institution that has nothing to do with them.
Or absolutely. Absolutely. Okay, so I shouldn't say absolutely because there's no numbers for this, right? We don't know. There's no accountability for this, right? When a hospital gets $100, the way they're spending, the hospital administrators are choosing to put this $100, right? Some of it goes to nursing. You have to, that's overhead. But where the rest of it goes, we don't know, right? It goes to a variety of different sources. And if I know anything after having a PhD in economics and being in the business school for the first, 5-7 years of my career, they're thinking, they went to business school too. They're thinking of putting the money into the highest return on investment, and the highest return on investment frequently happens in the stock market. And I will tell you, there was a paper that was published just a couple of years ago that looked at the COVID, I don't want to say COVID relief funds
Yeah.
that were given to hospitals.
Yeah.
Oh man, I'm forgetting what it is. 75 to 80 cents on the dollar of it went. Oh no, I'm sorry. Scratch all this.
It's okay.
We'll go to the so there was a paper just recently published. They found that for every dollar spent, or for every dollar negative profit the hospitals are reporting, 75 cents of it was lost in the stock market, in private equity markets, right? So then the hospitals turn around and they tell you, oh, our labor costs are too high, right? And they're trying to replace staff nurses with travel nurses, or travel nurses with something else, or understaffed units, right? We just have absolutely no accountability within the healthcare system where the money goes. We're not even splitting it to where if you get $100 for patient care, you have to spend $100 on something related to patient care. You can take part of the $100 and invest it in the stock market, and when it crashes, you lose all of it. So that's how sort of wild our healthcare system is. I mean, the economic model of it is wild. And people don't understand this, and patients don't understand this. And we think that, all of this money we're spending on healthcare, it goes to nurses or whatever. It doesn't, but it
How
should.
do we, maybe this is an unfair question, but how do we change the narrative about what the healthcare industry is?
How do we change the narrative? I think we find good people, we amplify the truthful narrative, and we don't let people who who are self-interested to, disseminating and propagating the narrative that's wrong. And you give it to nurses also, right? Because nurses, I feel like at this point in time, nurses are nurses and patients are the only two groups. If you look at like large groups within healthcare, there's administrators, there's insurance companies, there's policymakers, there are physicians, there are nurses, there are others, right? And patients. Of all of those groups, only nurses and patients are being hurt by the current healthcare system. Everybody else is benefiting from it. Physicians will say they're not benefiting that much, and they are truthfully facing some of the same problems that nurses are, especially as of lately, that a lot of, as of last 10 years, 20 years, that a lot of physicians are actually working for healthcare systems and not working independently. They are subject to some of the same pressures, but not to the same extent as nurses are. So nurses must propagate this narrative. Nurses must understand this narrative. Whenever I tell it to anybody, they're like, whoa, that all makes sense. Is this actually true? And that is true. I'm not making this up. You look at the federal registers of how hospitals are being paid, and it's all there. Quality is less than 1% for an average hospital. You can have high quality or low quality of care, and you will get 99% versus 100. You will get $99 versus $100. When quality matters that little, obviously there is not a return on investment on quality. There is a return on investment on volume and quantity of admissions. And that's where hospitals will staff only to the minimum to make sure the beds are open.
So what do you say to those that are still trying to move from volume to value? It seems like moving to value would hurt the financial return.
It's not going to hurt the financial return. Absolutely not. If you have a financial component that comes from value, right?
That's the
Originally,
point.
that is the point.
That's
Originally,
a,
when the value-based payment and purchasing models were first designed, there was an intent to bring those penalties for low quality, right? There was an intent to bring those penalties to 30 to 40% of the price. It never happened. They're still lingering around 1%. Maximum, I think, if you are really bad on all of the programs all around, right, you can get penalized 5%, maybe 6. But it's still not there, right? Everywhere else, across all of the industries, quality is about 30 to 70% of the price of the product. Think about it. When you
okay.
compete, when you buy a new cell phone, right? The competition is based on quality. So you're paying, 40 to 50% of the price of this cell phone is quality. For healthcare, less than 1%.
Wow.
And
Wow. Okay.
we know this. That's how our system is designed. So what we get, what we created.
Yeah. Well, it's making me really think about just how many people don't know the information that you're sharing today. And it
He,
makes me also go ahead. Go
no, I
ahead.
was gonna say the people who need to know this, they do.
That's the point.
Yeah.
But they do. But what about patients? What about their families? Maybe
No,
they should know.
they should. And they should demand better. And somebody
Well,
somebody has to take somebody has to make it good by nurses. And whoever that somebody is, it is a 5 million person occupation. You make it good by nurses, you unite this incredible coalition, you can accomplish anything.
let me ask you this. What do you think? Again, I don't have any data around this. I just got off the phone prior to this interview with a group of healthcare leaders who are saying now, so I can't validate this. And
Mhm.
if you feel uncomfortable, just don't answer it. But it seems like there are more and more nurses are starting to become unionized.
Mhm.
You know a little bit about that?
I know a little bit about that, and I'm all in favor of this, right? Because nurses need to have they need to have a voice. They need to be unified, whether it's unionized, whether that is the sort of the channel is chosen. It's better than nothing, right? It's better than having a disenfranchised, fragmented nursing workforce, right? Because when everybody thinks this is my box where I'm staying, nothing will ever happen, right? So nurses must unify. Nursing membership in the American Nurses Association is abysmal. Physicians, over 90% of physicians belong to the American Medical Association. Nurses are an incredibly fragmented, divided, dispersed, huge force that if it could be if it could be harnessed, it could be directed towards nurses could direct their strength towards so many issues, not only fixing healthcare and make it better for the patients, but lots of social issues. Why politicians are appeasing to, and I have nothing against auto workers or other constituencies or other unions, right? Why politicians are appeasing to those occupations, I, I understand. But if nursing was one of them, nurses could really make some huge headway on Capitol Hill, right? And if unionization is part of it, if that's a step towards it, as long as the unions can unite as well, right? Nurses could really become a very powerful voice.
Yeah,
And I
that's why I
really wish
brought
that
this.
happens.
Yeah, that's why I brought this up. So to close, looking ahead, how does the nursing human capital value model prepare healthcare systems for future challenges such as aging populations or advancements in medical technology?
Directly, right? You have to own your nurses. You have to own your nursing human capital. And that means that you have to invest in it. That means you have to work on retention. That means that you have to, when you take a new nurse on board, that nurse has to want to stay with you for the rest of his or her career, because that's how you get experienced nurses, right? That's the only way, by fostering a diverse, flexible and adaptive nursing workforce, and resilient, right? You have to be resilient to be able to adapt. It's how we can protect yourself from future crises. A lot of crises occur, obviously, unexpectedly, right? And when a healthcare system is running on fumes, when your major component of the healthcare system, which is nursing, is running on fumes, you're not prepared for anything unexpected, right? You're barely meeting your day-to-day demands. There has to be investment in it. That investment has to include a certain amount of slack. And by slack, I don't mean people sitting around on their phones, right? I mean resilience, right? There has to be room to move, right? Nurses need to have room to breathe and to think and to contribute their best value to the healthcare, right? It's not about task completion. It's not about you come in and you don't put nurses in a situation where they have to come in and they have a million things to do, and they don't have time to sit down and eat lunch, or they don't have time to take a break. They don't have time to go think about how to make patient care better or how to raise their voice, right? You have to build in that. I hate to use the term non-productive time, right? But you have to really invest in non-productive time for nurses so that nurses could be the best they can be.
Yeah, I'm walking away from this, if I can make it really simple. Without the nursing human capital value model, there is no healthcare transformation. Period. I'm
Mm-mm.
walking away from this knowing that um, without nurses advocating for their own value, there will be no healthcare transformation. But I'm also walking away from this thinking, how can leaders not see this opportunity for the long haul? Because short-term thinking isn't going to get us to where we want to go as patient populations continue to change, both aging and and young populations that are more culturally diverse than ever before. There's going to be some radical needs from those systems that begins with the nurse. And the nurse sees people as individuals, and that's why they're so committed to their job, because they see them as people whose lives they want to change, whose health condition they want to improve. And those are the type of people that are going to get healthcare where it needs to go. And I actually think that this is going to drive a change in the type of leaders that we bring into healthcare systems, which will eventually, hopefully, change the healthcare economic model. You've taught me a lot today, as you always do every time we talk. You've given me more time today, as you always do. But what I think you've done for our audience is you've awakened us to understand not just the complexities, but the simplicities of the things that we should be seeing and taking action on. I can't thank you enough for your time, Olga. You are an incredible source of information, and just keep going. I mean, what you're doing and what you're advocating for and what you're researching and know by facts and numbers. This message needs to continue to be amplified and heard by many who may have a perception of what healthcare is, while you're giving us an understanding of what healthcare really is. Thank you,
It's my
Olga.
pleasure.
No, no. Thank you. And to be continued. And again, appreciate your time. And as we end every show, when you lead in the age of personalization, you will see things that others don't. Do what others won't, and keep pushing where prudence says quit. Thank you, Olga. Thanks for listening to Personalization Outbreak. Make sure to subscribe so you never miss a show. If you enjoyed the content, visit ageofpersonalization.com to check out our free streaming video series and learn how to get involved in the movement. I'm Glenn Llopis. I wish you a good day, and remember, without strategy, change is merely substitution, not evolution.